in our team, we have 3 PhD students from system engineering and AI engineering with 2 of their faculty advisors. Mohammad Yaqub, who is an assistant professor of computer vision at Mohammed bin Zayed University, and Mesut Emre, who is a systems engineer at Khalifa University. With me is Himanshu Upadhyay. He's from IIT Delhi and also a machine learning engineer and a student of Khalifa University. So we're going to present our project. We've named it Renaissance, essentially trying to see how we can deliver renal care to the huge masses of people who suffer from kidney injury worldwide. Kidney disease is very common. 10% of the world's population has kidney disease. The areas marked in red are the areas which have most amount of kidney disease worldwide. 850 million people worldwide have kidney disease, and largely they live in the global south. And there are not enough nephrologists like me to look after this population. We are particularly tackling one aspect of kidney disease, which is in-hospital acute kidney injury. This report came out in 2012 from NHS, National Health Service of the UK, that 1 in 5 all hospitalized patients get AKI, acute kidney injury. And there's actually a global initiative by our international society to reduce the number of preventable deaths related to acute kidney injury. So why is acute kidney injury important in hospitals? It increases length of stay, increases mortality. This is data from our own healthcare system. SEHA is the National Health Service of Emirates of Abu Dhabi. The average length of stay is 5 to 6 days, but if you have AKI stage 1, increases to 12 days, and if you have AKI stage 3, which increases the length of stay further, of course, mortality goes up. And this is not just us. I mean, I know one of our panelists is from Brigham. He will remember this landmark paper, which came out in mid-2000, which showed that even mild AKI, that is AKI stage 1, 44 micromoles rise in creatinine increase the length of stay by 3.5 days and increase the risk of dying. And why is that relevant? Because in a capitated healthcare system, we get a fixed amount of money for the diseases we treat. And AKI with bacterial pneumonia with AKI, we get 21,000 dirhams. But as my previous data showed, it will no way cover even 12 days costs. But if the patient ends up on dialysis, we lose money on each of these hospitalizations. So increasingly, in-hospital AKI is considered a patient safety thermometer, and it increases the risk of, it is more common. These are our own data. It costs us 3 to 4 million dirhams per year to look after these patients on dialysis, and 1.3 million dirhams for CRRT. So this is an expensive problem. Of course, rich countries like UAE and USA can afford it, but large countries, countries across the world where there are not enough dialysis machines or the capacity, they will not be able to afford. So what have we been doing? This is our master plan. So we want to promptly recognize acute kidney injury, implement changes to decrease AKI, and develop a prediction tool. So the problem to implement AI and machine learning in healthcare is lack of structured big data. Facebook and Amazon know everything about me because they have been collecting data effortlessly through their WhatsApp, through Facebook, through Instagram. EMR data is largely garbage, and every practicing physician will tell you that. So we've been trying to structure our data to try and do machine learning. So this cartoon here, that you have to have a good, effective data strategy to develop small, structured, clean data to do machine learning. Now, we have Cerner as our EMR in the whole healthcare system, which has been helpful. So we were the first healthcare system outside the Western world to build in the acute detection, AKI detection algorithm in our EMR. So this has been working for the last 3 years. So we just copied this algorithm, which was mandated by the National Health Service in all the hospitals in the UK and built in our EMR. So we've been collecting this data prospectively. So we've also developed some clean, structured order sets to help a non-expert do hypokalemia, hyperkalemia management, hyponatremia, and hyponatremia management. So we built in FINA, Phi-urea calculators in our own EMR. and also TTKG and other calculations. We've also digitized our dialysis prescription, and we've also built in a KTOV in our EMR. We've also digitized our CRRT prescription to capture the prescribed dose and delivered dose. In addition, we've mapped out what are the gaps in our CRRT care delivery, working with our system engineer colleagues led by Mehmet Emre, one of our partners. And largely it is related to diverse backgrounds. So UAE has more than 200 nationalities who call this home. Most, actually the nationals are only 10% of the population. So most of the healthcare system is run by people like me who've been trained in the West, but there are people who come from Europe, people from North America, South America, Central Europe. And so there are different practices. We've been trying to streamline those. So as I mentioned, we've digitized the CRT prescription. We've integrated all the CRT machines to our EMR. So all the data is captured minute by minute. And we've now set up training programs where we are trying to streamline our practices. All this has allowed us to create a structured big data in our EMR. So prediction is not new. I mean, as you know, when Google entered the healthcare space, the first domain they picked up was acute kidney injury, and you may have seen this paper which came out in Nature. So we believe that our data will allow us to refine this and build much more better algorithms. We want to tackle a few unique use cases like perioperative risk, AKI risk calculator, and the big goal is to develop a AI tool to help with volume assessment, hemodynamic assessment. So we've built some AKI risk calculators, which we are further refining based on the data we've accumulated in our EMR. So, but the main goal is to develop a AI-assisted tool to get a non-expert to use the handheld point-of-care ultrasound to assess the whole complete hemodynamic circuit. Now, as you know, point-of-care ultrasounds are now getting cheaper, more reliable, and get very good views. In our team, Mohammed Yaqub is a AI computer vision scientist. In his last job in GE, he developed the algorithm for the fetal anatomy scan, which is present in all the GE Voluvision machines. So now his algorithm is being used for millions of women worldwide to detect fetal anatomy scan. So we've already built a basic algorithm based on our echoes, which hopefully it works here. It will calculate the ejection fraction as soon as the images are uploaded to this GitHub link, which is in our presentation. Sorry, stop moving. Okay, so this is me scanning a heart of a gentleman on my phone. This is my iPhone, and I am using a Clarius device to capture the echoes. These images. And we were now funded by Econos. It's a ultrasound startup company who has supplied us 10 ultrasound machines, which we have deployed across the whole hospital. So we've started the first focus academy in the Middle East in SSMC, and we are training our trainees to capture these images in our hospital, which are being stored in our apps. So these are our devices that are deployed across the whole hospital, in ICUs, in HDU, in medical floors. And this is us training our trainees to capture these images, which are going on our packs. So Econos already has developed a small AI tool to assess ejection fraction and annotate the chambers of the heart. This is a parasternal view. One of my residents is doing under my supervision, and she's capturing that. And we are trying to bring about a culture change in the hospital so we can bin the instrument of 18th century stethoscope, and we can start using point-of-care ultrasound to do objective volume assessment. So this is created growth and value for our organization. We are, as I mentioned, the first focus academy in the Middle East, and also Baxter has declared as a center of excellence for CRRT, and we will be training people from whole of Africa, Middle East, and Central Europe in our hospital. So we presented this in a hackathon organized by Ericsson and Ministry of Economy, and which we won. And we've also won the Patient Safety Award for UAE and Middle East recently for our work on acute kidney injury. Thank you very much. So we are open to open any questions from the audience.
Judges? Yeah, I guess I should ask a question because I'm a nephrologist. So I'm putting a paper in chat, which you're probably familiar with. I'm gonna put it out to hosts and panelists. This is a paper by Perry Wilson and BMJ last year that tried to identify patients with acute kidney injury, randomize them to alerts, and wasn't actually able to improve outcomes, to his frustration. I mean, he talked a lot about ways and why this study might have found what it found, but in the end, I mean, it was a very unsatisfactory result. And that's been the kind of end result of every AKI intervention that's been put to an RCT. So I think, you know, I think it's an important research question to figure out, can we get an AKI intervention that actually works? And there's lots of recommendations of the sorts of things you might be able to do. But I guess the question is, you know, if you are out there, you know, as an innovator, as a startup trying to raise money for this, where's the data that an AKI identification scheme actually will help AKI patients?
Actually, our goal is not just that, to develop a complete management pipeline, you know. So you have to realize that I'm a part of the ISN as a mentor. I'm training nephrologists in Africa. One of the one I'm training in Somaliland is one nephrologist for a population of 10 million. So what you're talking about is a Western healthcare system. And this paper was run in some of the top hospitals in America. I think so. I mean, let's assume you're a midwife delivering a woman in middle of Africa who's had a postpartum hemorrhage. How will you assess volume status? There's no physicians around, you know. And what we want to develop is a tool which will be open source, which will allow us to integrate with any handheld ultrasound devices. You put in some key numbers, and it gives you some basic assessments of what the volume status looks like. Does this patient have early AKI? And as you know, as a nephrologist, you know, the most common cause of AKI in hospital is either fluid overload or hypovolemia. And that itself, we don't do very well. As you can see from the UK itself, that 20% of all hospitalized patients have AKI. Now, if you go and speak to the doctors in this in sub-Sahara or parts of India where there are not many doctors around, the main thing they want us to teach is volume assessment, how to train the advanced nurse practitioners or advanced healthcare professionals to do volume assessment, to detect early AKI. So we want patients to come to hospital, not go with a problem which they have developed in the hospital. And I'm sure you will agree with me that volume assessment could do better even in mature systems like yourselves, but immature systems, training capacity building, of course, is needed. But what can we provide? The fingertips, which will help a non-expert do things which you and I can do.
Maybe I can follow up with a question that's maybe not necessarily technical, although I agree that even the IBM Watson work shows that sometimes you just cannot get good correlations with these approaches. But the question I have for you is, when you present here today, it seems to me that you already have developed everything. So you're in the implementation or testing mode, right? Is this fair? Like some of the other teams are nascent in their activities and they have a whole plan of what they're going to try, and it's like exciting and how we can help them.
So,
you're already too advanced for this. Is this true or?
No, actually, so what our efforts have been largely is on creating structured data. Because what happens is most people look at open source data sets which are not relevant to population which I treat. I mean, most data sets which are publicly available are for white population, Western population. So currently you'll be surprised to hear that average age who ends up on dialysis in UAE is 40, 65 or something in UK, in US, and 72 in UK. My patients are mostly brown and black compared to your data sets, which are mostly white. So what we've been working on the last 3 years, this is 3 years effort, is to create structured data set for detection. Now, the second element of the problem we're trying to solve is volume assessment. The most common cause of AKI in hospital is not vasculitis, not GN, it's fluid overload, obstruction, or dehydration. And this could be de-skilled enough by these point of care ultrasounds that a non-expert can do that. A volume assessment. A paramedic looking after someone who's had a, say, hemorrhage on the street will know, using the point of care ultrasound, can I give volume or not? A critical care outreach nurse who goes and makes an assessment at night time will know that this shortness of breath is related to fluid overload versus a pneumonia. And that's what our goal is, to make the job of volume assessment a skill currently for which we use a stethoscope, a chest X-ray, echocardiogram, and a formal department ultrasound. All this could be done by one handheld ultrasound. Most of these devices are IoT devices, and they have softwares which run on cloud. But if algorithm can run on that cloud, as long as they capture the images, they will. We can give fluid, don't give fluid. If I could give you a better example, when everyone in the hospital starts using ECG, understood ECG, then American College of Cardiology American Heart Foundation could make ACLS, because you don't need an EP physician to read ECG anymore. Anyone can read ECG, which means that you can build resuscitation protocols, which can be done by everyone. So that's our goal. Acute kidney injury could be done, managed better if everyone could understand and speak the same language around hemodynamic assessment.
Yeah, and I would like to add a bit more on top of that. So, so far we have been doing mostly R&D, and we are just collecting data. So we are still like very far behind when it comes to developing a product or a platform. So answering that question from Dimitra, that yeah, we are not very forward, compared to other participants. We are yet in the development phase. We are just doing R&D, trying to collect local data to make sure the algorithms make sense in the local scenario. Thank you.